Hi, I'm Dr. Brian Kaufman of the CLL Society, the Executive Vice President and Chief Medical Officer, and I'm here at ASH 2023 in sunny San Diego.
And I'm Dr. Adam Kittai. I'm an assistant professor at The Ohio State University, where I specialize in CLL and Richter's transformation. Really excited to be here at ASH.
It's great to have you, and you're presenting some really important research on Richter's transformation. First, can you remind the community what Richter's transformation is and why it's so important that it be studied?
Yeah, so Richter's transformation is when chronic lymphocytic leukemia turns into an aggressive lymphoma. And the reason why it's so important to have new trials and new therapies for patients with Richter's transformation is that unfortunately patients with Richter's transformation don't really have many good therapies out there, and the therapies that we do have there don't work or provide durable remissions for our patients. And interestingly, patients with Richter's transformation, although you'd think that they might do as good as normal aggressive lymphoma, unfortunately they just do worse. And it's probably because they have the concurrent CLL with the Richter's transformation.
And there is, just to make a small point here, that some people do well, and there's people who get this de novo Richter's versus the Richter's that evolves from the CLL. Can you just spend a minute on that to explain to patients and why that's important for them to understand?
Sure. So in patients with Richter's transformation, you can either have CLL that literally turns into the aggressive lymphoma, or you can have CLL and just so happen to get aggressive lymphoma, and it's not linked to the previous CLL. In patients who have CLL, who just so happen to get aggressive lymphoma, those patients actually do pretty well, similar to normal aggressive lymphoma. And how we determine who those patients are is actually through what we call clonality, and it's a special test that just tells us, did the aggressive lymphoma stem from this DLL? Another surrogate that we think is a good surrogate for clonality, but it hasn't been proven, but we're pretty sure it is in patients who have CLL and get therapy and then develop aggressive lymphoma, those patients do much worse than patients who have CLL, have no therapy, and get aggressive lymphoma. And so those are two delineations to determine really how well we expect for somebody to do with Richter's transformation. And actually, one of my abstracts here today looks at Richter's transformation that's developed after patients have received small molecule inhibitors without chemoimmunotherapy, so really a modern cohort of patients. And we showed just that if you've received small molecule inhibitors and then develop Richter's transformation, you do worse than if you receive no therapy and then develop Richter's transformation.
And there's been some recent research that suggests that prior chemoimmunotherapy may increase your risk of developing Richter's. That was always a question. We knew it increased your risk of myelodysplastic syndrome, and now there's a suggestion it might also increase your risk of Richter's.
I think it's actually not necessarily that it increases your risk of Richter's. I think that if you have CLL that requires therapy, you are more likely to get Richter's transformation. And I will say, though, that Richter's transformation is a relatively rare event. So one of my colleagues at Mayo is presenting his abstract here that looks at Richter's that's developed in the era of our new therapies for CLL, and he shows that basically the risk of Richter's transformation in anybody with CLL is around 1 to 5%. So this is not something that the vast majority of our patients with CLL will ever have to deal with, but it is one of those situations that we take very seriously.
So, and it's a screaming unmet need because, as you say, the therapies have not been tremendously successful in terms of giving durable responses. And there's a hope that maybe some of the cellular therapies might help, and with CAR T kind of leading the way. Can you talk a little bit about your research in the paper that you're presenting here that looks at the CAR T therapies in CLL?
Yeah. So CAR T has revolutionized the way we treat diffuse large B-cell lymphoma. However, the clinical trials that led to the approval of CAR T for diffuse large B-cell lymphoma largely left off patients with Richter's transformation. However, CAR T is actually approved for Richter's transformation, specifically Lysocell, one of the CAR T products, because it's approved for transformed non-Hodgkin's lymphoma, which CLL to Richter's transformation is. And so we previously published our experience at OSU looking at one of the products called Axicell, And that was only in 9 patients. And so we wanted to expand this research, get more patients, and have more longer follow-up to see how well this works for patients with Richter's. So we did an international study, both in the US and in Australia, and we collected and found 69 patients who had CAR T for their Richter's transformation.
That's a huge number with Richter's because it's a rare disease. CLL is a rare disease, and then only 1 to 5% of those people develop Richter's, so that's a huge number.
Yeah. And these patients, they received typically 2 prior lines of therapy for their CLL and 2 prior lines of therapy for their Richter's transformation. So that's 4 prior lines of therapy. And really shows you that these patients really had nothing else, right? They already got 2 prior lines for their Richter's, which is a lot of prior lines for Richter's also. And the majority got that Axicell product, but they also got Lysocell, Tisocell, or Brexocell. Those are the 3 other FDA-approved CAR T products for diffuse large B-cell lymphoma. Brexocell is for mantle cell lymphoma. And what we found is that for this 69 patients with Richter's transformation, the overall response rate was about 60%.
That's amazing.
Yeah. What's more important here is that 40% had complete remissions, and those patients who had complete remissions had a duration of response, meaning how long did their complete remission last, of around 2 years, right? So that's a huge thing. And the fact is that there are some patients who are still in remission with their Richter's. I have a couple of those patients who are doing quite well. And so we're hopeful that this CAR T will actually be used for Richter's more often. And I'm thinking that it probably needs to be used in an earlier line of therapy. Waiting for someone to fail 2 prior lines of therapies to get CAR T is waiting too long. And the reason why I say that is when we looked at various factors that might predict how someone would do with this therapy, if patients got it in an earlier line of therapy, they did do better.
CAR T is not for the meek. There's adverse events, and these patients were pretty beaten up. How did your patients do? What was the treatment-related morbidities and mortalities? What were the side effects like? Cytokine release and the neurological toxicities, I suspect.
Yeah. So CAR T cell therapy and bispecific antibodies both come with a unique set of side effects. These side effects are called cytokine release syndrome. Basically, it's like if you have a bad infection, you get fever, you might get chills, your blood pressure might drop. And the other one is a neurotoxicity, where you have trouble writing and walking, and your memory might be an issue. Both of these toxicities are self-limiting, and we have good treatments for them, so it's not a reason not to get these therapies, but it's something that we know of and will make you aware of if you are going to get CAR T or bispecifics. So in this study, the rate of CRS, or cytokine release syndrome, and neurotoxicity were a little bit higher than what we expect in diffuse large B-cell lymphoma. But actually, they are sort of equal to the amount of toxicity that we saw in the Lysocell for CLL study. And so about 15% of patients got grade 3 cytokine release syndrome or higher.
Which is pretty serious, yeah.
Requiring hospitalization and medication. And about 35% of those got neurotoxicity grade 3 or higher. And the rate of infection, which we also see with CAR T cell therapy, was about 20% grade 3 or higher. So these patients did have a high rate of toxicity, but not so much higher than what we expect from CAR T, but a slightly higher than what we expect from typical CAR T for aggressive lymphoma.
Were there some patients who didn't make it as a result of the therapy?
Yeah, so we specifically had one patient at OSU who didn't make it because of therapy, and his CT scan that was done because he got a bad pneumonia actually showed that he was in incomplete response. So, and I unfortunately did lose a patient to COVID too. But for the most part, these patients, as we said, really don't have many options, right? They've already used 2 therapies for Richter's transformation. And so I think that overall, even though their toxicity is there, I think the benefit of the CAR T outweighs the risk.
So any final thoughts about where this fits in and where you see this going, where the research needs to move forward?
Yeah, so we now have 3 prospective clinical trials using CAR T for Richter's transformation. One is available at OSU, and that's zanubrutinib plus Lysocell for CAR T. One is available at City of Hope, and that's ibrutinib plus CAR T plus nivolumab for Richter's transformation. And another one is being run by the pharmaceutical company, and that's going to be Brexocell for Richter's transformation. So I think that always it's important when we do retrospective studies that that's not the pinnacle of our data, right? We really need to do prospective studies, look at how drugs do, and then follow patients along into the future to really see what the benefit is. And so I think that we should still use CAR T-cell therapy for Richter's transformation. I think it definitely has a role. I, for one, really try to get my patients to CAR T. And I think we'll find out soon from these prospective trials whether or not and which patient populations we should use it in.
And I love the fact that those two institutional studies are looking at tweaking the immune system, because the immune system in CLL, and specifically our T cells, often are not as functional as they are. So trying to use a BTK inhibitor or a checkpoint inhibitor to try to bring them up will help.
Hopefully.
Yeah. Well, I'm excited about this. Thank you for what you're doing.
Yeah, thanks for having me.